I've got it.
Yeah, just make sure.
Yeah, recording.
That's it.
We're recording. Okay. This is good. Yeah, don't forget to hit record. Thanks, Jem. That would have been bad. It
should do it when you start, but we can always edit it down, can't we?
Yeah, no worries. No worries. We can do that. Okay, let's get rid of that. Reminder saying I've got a webinar starting in 10 minutes. I don't need to see that. We're already here. Okay, so at the end, Alif, Jem's made as a kind of closing screen. Okay. It just gives some details of some webinars we've got planned in the next couple of weeks on there. Directs them to the Facebook just to sign up. Also, it just tells them brief details about how they get CPD for this, so they'll get an email in the next couple of days, just so they can claim the CPD. Mm-hmm. Cool. Time are we? 10 minutes too.
So they'll get an email hopefully tomorrow, and it's got a link in it that just lets them click on to fill in the feedback form, and then they'll get the CPD.
Yes.
If they've not got a ProDental account, it gives them a link to sign up, and then they can get their feedback.
It's all free though; they don't have to pay.
It is, yeah.
This is perfect.
But just in case there's questions about how to claim CPD, they just need to wait for the email tomorrow.
Yeah.
If there's any questions, then direct them to the info at ProDental.
Yes. Don't ask me, because I won't answer it. As you know. As you know very much. Okay.
My router is just here, actually. It's the reason I've moved. I've just been told my internet is slightly unstable.
Oh, for goodness sake.
I hope that's not going to be a problem. Okay, don't worry. Okay. If not, I'll move back to where I was before. Okay.
That's fine. It's coming through okay at the moment, so it's looking good.
Okay.
Yeah, all good. So how do you want me to introduce you, mate?
Alif is all good, man.
Mm-hmm. Okay. And you're practicing Leicester, isn't it? Oakdale.
That's right, yeah.
Fully private?
Pretty much. Actually, I've got an annoyingly small NHS contract, which is going to ruin everything now, isn't it, apparently?
Oh, no. Well, at least you might get some money through from it.
That's true.
You get something coming in. We're fully private. We've got nothing coming in at all. It's kind of challenging. Hey ho.
Yeah.
Does that make sense?
It's just start counting all of those outgoings, don't you?
Oh, I know. We've gone through everything we can and kind of cancelled everything we possibly can. You kind of look over to kind of Italy, Spain, and they're locked down for kind of 2-3 months. So it's kind of crazy. But speaking to one of my colleagues over the weekend in Germany, German dentist, and what they did there is they're testing everybody. And if you've been tested and you've had it and you're not infective, you get like an app, and you can go back to work. So most people over there are working. They've got it right.
This is how it should be.
It's absolutely, because they're testing about 500,000 people a day. So, and they're testing people repeatedly, and once they've had it, they're clear they can do anything they like. So in dental practice,
this is
they
how
work
we will
pretty
get
much
back
as normal.
Yeah,
they work because they've all been tested. They're all clear. All the patients are tested. They're clear, and they're not treating kind of high risk patients. But other than that, they're doing everything pretty much normally.
You know, it's not beyond the realm of our ability to do the same. To be honest,
it isn't. It's kind of yes, it's expensive, but it's blooming expensive for the government to pay all this furlough stuff for people. It's going to cost them a fortune. You think it would be a lot cheaper to do this? It's another option, because they're not furloughing people in Germany; they're all working.
Yeah, definitely. The economy stopping, we will end up paying for.
Of course we will. We're the only people who can pay for it as the taxpayers, so we're going to end up getting massive tax bills in the next few years.
Definitely. No, it's not a good thing for anyone, unfortunately, is it?
How long do you reckon it'll go on for? A couple of months or a month?
Yeah, I reckon, I'm hoping a couple of months. I'm hoping. Yeah. But I read a really nice article, actually. It was called the Hammer and the Dance.
Okay.
So it was all around this business of R0. I don't know if you've come across this. So the R0 is how many people one person is likely to infect.
Okay.
So if you have an R naught of 2 or more, then you can imagine you get exponential growth.
Yeah.
And that's when an epidemic or a pandemic starts.
Yeah.
So what the government are trying to do is they're trying to reduce R naught by getting, and you can either do that by, vaccinating people so that one person can't infect somebody else.
Yeah.
Or you stop people from meeting so that physically people can't infect somebody else. You drive the R naught down.
Yeah.
So if they get on top of the R naught, they'll reduce the pandemic, and that's called a hammer. All right, just get R naught down. Okay.
Yeah.
And then the dance part is trying to keep R naught as close to 1 as possible. Okay, because if it's close to 1, then you're not getting this exponential growth. It's controlled.
Yeah,
the infection from one to another. And apparently the way they like to do this is that they would then look at what measures are causing the biggest economic burden.
Okay.
And then lift those. Yeah. So lift that. So let's say R naught is 0.3, then they've got a little bit to play with, haven't they, to get to 1. Yeah. So let's maybe lift, I don't know, schools. Let's let schools happen again. Okay. And then if R naught gets to 1, it's fine. But if it gets too high, then they'll close the schools again.
Yes.
So that's the long-term management for the epidemic or the pandemic, which I thought was a very, very interesting take on how to do this. So we're very much in the hammer phase at the moment.
Yeah, absolutely. It's kind of weird because we've been self-isolating as a family until today, and we're going to go out today and we've got to go and buy some stuff for some neighbours. I'm pretty certain 2, if not 3 of us have definitely had it, but I don't know. But we can go out there, and if we haven't had it, we can get infected, and it's crazy.
Yes. Yeah, it's really, really worrying. Really worrying.
Yeah. I mean, we live in Derbyshire, and round us, they've kind of closed all the main roads now, because up until probably Saturday, it was like holiday time. There were people on bikes, people walking the dogs, people going out for days out. They're everywhere. Yeah. It's just like, so they've locked everything down. They've closed the car parks. They've closed the park just to try and stop people congregating here, I think. So we don't want your bugs to go away.
I think that's sensible. It's a shame people won't manage themselves, isn't it? But then again, did you see that thing about the Scottish CMO? Unbelievable.
How to lose your job very quickly.
You know what? This is it. And I felt really sad because you think that sometimes, I had to think about it yesterday, but as healthcare professionals, because we're put on pedestals, if we slip up, we have to be knocked off. We have to be.
Absolutely.
Because if we're the ones giving the guidance to the government and the like, then absolutely.
If you're not following it, it's okay for you, I'm all right. Yeah, absolutely.
Yes, exactly. Yeah, but sad business.
Okay. So we got.
So have you got a lot of these webinars planned now?
Yeah, we've got. It's been great. I've kind of been asking a lot of mates really, and I think virtually everybody said yes, which has just been amazing. So we've got about 30 or something planned over the next couple of months, month really. So yeah, that'll be good. No, we've got some good ones. We've got some good ones coming up as well. So yeah, so I think we're running this one today. I've got some stuff to do for Health Education England tomorrow, which I have to speak to Gemma about afterwards. We've got more work to do. And then we've got a couple more Wednesday and Thursday this week each day. And then next week, I think pretty much every day.
Oh, wicked.
So yeah, it's good.
I am here, guys. I'm just working at the same time, so I am here.
I thought you were ignoring us. Oh, Gemma. No. Okay, are we ready to go? Shall I hit broadcast?
Nearly 11.
Okay. Should we be like the CDO and put the slide up and then not do anything for 10 minutes?
Yeah.
I need to look this way, don't I, on the CDO?
You need to look this way, and you need to have 3 or 4 other people coming into your room at the same time. To look everywhere but at the screen. Just look sideways. Oh, Our glorious leader. She's stunning. I suspect she will lose her job, I think, but there you go. Who knows?
Yes.
I can't see.
Yeah, CMO of Scotland did, then I suppose CDO.
It's a complete lack of leadership, isn't there? But hey ho. Right, I'm really ready to hit the button. I'm scared.
Go on then. Yeah.
Let's hit it.
Yeah.
Okay. Okay. All people joining. Actually, a number counter going up in the corner. Okay. Welcome to everybody who's joined. Really pleased that Alif is running the first of our lockdown webinars, and we've got a series of about 30 over the next few weeks planned, and we'll share later on after this how to find those and access those. We've got over 100 registered for this webinar, which is fantastic. Tough times for all of us, so it's completely free. We're not taking any payment. Alif's not taking any payment. We're just doing it because we're trying to help our fellow colleagues. Any questions as we're going through? If you just ask a question, we're going to mute everybody's mics, but if it's a good question, we'll open your mic up. And Alif's quite happy to take questions as we're going through. Want to make this as interactive as we can. Alif is a mate from ITI, really, from my dental profession within the ITI. I've known him a number of years, always been incredibly enthusiastic, has got some great concepts with regard to digital dentistry, way better than mine are. So I'm going to pass over to Alif, principal dentist down in Leicester. Okay, Alif, over to you, mate.
Thank you very much, Rob, and thank you for that kind introduction. And a warm welcome to everyone who's joined in today. Yeah, I've been looking forward to this. I've been twiddling my thumbs for a little while, actually. And I thought, they've set the stage really nicely because, it's really daunting when you have to do a webinar and you're following from someone really good. But given that the last webinar people saw was the CDO's one on Friday last thing, today should be a shoo-in, really, shouldn't it? Well, once again, a warm welcome.
Good morning, welcome to Oakdale.
Oakdale Dental, transforming smiles since 1937.
So that's the dream, isn't it? That's the glossy, slick bit over the top, the veneer, if you like. But it's hard, isn't it? It's difficult to get this stuff right. And so I'm going to try and talk a little bit about how to help our patients in the best way possible. I want to talk a little bit about how we can smooth our workflow a little bit, because there were always pain points for me when I was practicing dentistry. There still are, there's still loads. So the more we can manage, the more predictable we can be, the easier things get, and the more times we have success. So what we're going to do today, I'm going to learn a little bit about how digital dentistry is so much more than just doing crowns in a day. I'm not really going to talk that much about CEREC, the sort of the general workflow that I suppose is the thing that I normally teach commonly. But what I do want to show you is how digital workflows have really helped me in my planning and also communication with various people. So we communicate with patients, and I like to pride myself on being able to communicate well with patients, but I'll show you how we can enhance that a little bit. Need to communicate well with the lab to try and give them all the information they need so that they can get the best chance really of getting a successful job. And also, I do a lot of implant treatment as well. So I'm going to show you how I try to ensure that I'm communicating my planned placement for implants and the like into the mouth really accurately so that we can have smooth and seamless surgery. Okay, so who am I? So this ugly mug here is the principal dentist of Oakdale Dental. So it's a practice in Leicester, and we've been there for a while now. And I really enjoy being a principal, actually. I think it's good fun. It's good fun. I've got a really good team, and I'm really proud of them. I'm really a bit of a geek, dental geek, so I've been on courses after courses after courses, and I really enjoy learning. And luckily, when I thought I might know one or two things, I really enjoy teaching as well. So I lecture on lots and lots of bits, but I also have a particular interest in digital dentistry and also in implant dentistry as well. And I wrote a book called The Smiling Dentist. This is my practice in Leicester, Oakdale. This is our waiting room. And this is the book I wrote, Smiling Dentist. Now, why did I do it? I find that patients who you take the time to engage with, to educate, to explain stuff in a way so that they can understand dentistry the way that we do, I think those are my favorite patients. They get it. And you know, as a dentist, that if you were going to ask for treatment to be done, you wouldn't always go for the cheapest option. You wouldn't always go for the smallest intervention because you can see the value in doing more. And I feel that if we can educate our patients in a way that allows them to see the world through our eyes, then they would probably make really good choices as well. They'd want to have treatment that lasts a long time. So the reason I wrote the book was it's meant to be a jargon-free text that patients can take, and each chapter is a different topic in dentistry. And then I've just tried to simplistically explain the world from my eyes. So this has been a really nice thing that we do at the practice as well. We have used DSD a lot. So this is called digital smile design. And the concept of digital smile design is, I feel, a really good communication tool. Okay, now things have moved on, so I use different tools now, but this was the start of it. This was where the penny dropped. You see, selling, I don't think, is a dirty word. I think selling is imparting value in something and then seeing if your patient sees that value too. If they do, then they will say, yes, I would like to proceed with treatment. If they don't, they won't. But if they don't, they'll also understand a little bit better what doing nothing might mean for them as well. And what it does is it opens up the opportunity to have a conversation, and it opens up the opportunity to consent patients really well. And I really enjoy this part of my job. So if I see a patient, we take some photos, and then we overlay what a perfect smile, the proportions for a perfect smile might look like, then rather than me having to tell a patient, oh, you've got short teeth, you've got this, you've got that, you put this over and you just say to them, well, look, this is what a perfect smile might look like. What do you think? And they start telling you about how they think their front teeth are a little bit square and could do with lengthening a little bit. They tell you about how the positioning of the teeth could be improved. And then it also helps you to have a conversation, because you can see up on the top left-hand side there, and to an extent on the top right, we wanted to deliver the perfect smile. We have to do a bit of gum contouring. Now, not everybody's going to be up for crown lengthening. Not every dentist is up for doing crown lengthening. But if you've had that conversation about crown lengthening beforehand, then let's say they decide, yep, I'm not going to have it. I'm really happy just to have the restorations done, and that's all. And then at the end of the job, you show them, oh yeah, do you remember the little bit of gum there? You can see it's a bit longer because we expected it to be like that. Rather than them asking you why their perfect smile isn't perfect at the very end. Because that's an embarrassing and difficult conversation to have, especially when a patient believes that what they're paying for is the perfect smile. Let's talk a little bit about pain and pleasure. Everybody, every single human is about pain and pleasure, okay? And we all gravitate towards pleasure. We all want to fire away from pain as much as we can. What makes us all unique and what makes the human tapestry so beautiful and varied is that what we attach pain and pleasure to is different. And that's why we're so, unique, and everyone is different. But I think most dentists can probably agree that a pleasurable experience in our job is transforming someone's life, providing good, smooth treatment, everything goes well, treatment that lasts a long time. And I suppose, yes, getting paid and getting rewarded, that once you've given to the universe, given to that patient, then yes, maybe we should be rewarded in return as well. So what's pain? Pain is failing treatment, stuff that doesn't fit, stuff that isn't accepted by the patient, unhappy patients, complaints. And let's face it, I think we've probably all been there where we wish we could just get rid of some of these people, happily give the money back, and just have not another sleepless night. We want to avoid that all we can. Okay, and what we want to do is try and gravitate towards having as much pleasure and as little pain as possible. So I came across a lovely paper actually, and what it did was it tried to work out why restorations fail. So I'm quite happy to take a photo of the screen or whatever, and this is a really good journal to have a look at. Essentially, I'll summarize though. The patient factors were things like oral hygiene, how well they complied with treatment, either during or recall afterwards, what the oral environment was like, and if there was bruxism and things like this. And those are patient reasons why things might fail more quickly. Okay, but there are also dentist factors as well. So if our choice of treatment is poor, the way we prep, the way we do impressions, these kind of things, if our rigor, I suppose, in providing treatment is poor, then it's never going to work. So remember today, I'm going to focus on one facet of our workflow, but that doesn't excuse doing poor dentistry. Yeah, we've got to try our best on all the small things as well. Okay, so these are small ways that we can try and overcome the modes of failure. So this is just, as I say, just being rigorous about the small things whenever we're doing each step of our dentistry. But the thing with aesthetic dentistry or cosmetic dentistry is that we've got the parameters, I suppose, that we would look for, okay, marginal fit, poor, leaking, blah, 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 those kind of things. But there are also things where everything can fit beautifully, but patients might still be, or we might still be unhappy with the way things are, okay? And then there's all these different things to think about, okay? Value, chroma, proportions, line angles. So all these kind of cosmetic factors that we can diagnose as well, because we diagnose it in a smile that wasn't right and we were going to improve. So if the job that we fit or bond or whatever, at the end of it still has these compromises or issues, then there is still an issue there, still a problem. The one that annoys you, okay, and the one that certainly annoys me is the subjective one, where everything looks right. Okay, as far as you can discern in terms of protocols, proportions and the like, color, everything's nice, but patients just turn around and say, I just don't like it. Okay, and it happens to us all. Okay, so the point I'm going to make today is, why don't we have a system in place to try and make that happen before we've commit to our final restorations? And this is nothing new, okay? So this is provisionalization. This is basically having our patient have the opportunity to see their smile before we fit it for them. Okay, so I'm going to take you to her. She's actually a lovely patient. She looks grumpy as hell there, but she's a lovely, lovely lady. And this is Ingrid. Okay, so Ingrid came and presented with, you can see, a smile that she was unhappy with. Okay, various different things. There's gaps there, there's proportional issues, cracks, there's color, there's restorations, failing, all the like, okay? So there's definitely some stuff that we can help her with. Okay, so we did a few things to try and help. So what I use a reasonably fully digital workflow. And so when I'm doing digital dentistry, I try and think back to what I would be trying to convey to a technician in an analog way. And essentially, the most important thing with our first steps, planning a wax up, is instead of giving our technician just an upper and lower model, which is what maybe some of us do, some of what I definitely always used to do, and hoping against hope that they're going to give us something right, we know that a smile needs to fit into a face. Okay, so if you can give them as much information about how the face looks, okay, so what I've done here is I've used an app which is available on an iPhone 10 or anything with a face scanner, okay, Face ID. Then you can get this thing called Bellis 3D, which allows you to scan your patient's face. And then that can be converted into an STL in the same way that a model can, yeah, a scan of a model. And that allows you then to orientate the upper model so that it's exactly where the smile should be. Okay, so that gives you two things. It gives you the center line, gives you cants, it sorts that driving of the smile out from the first step. And then if your technician then starts waxing teeth up digitally, can then put it back into the face and see if it just looks right. Because normally by eye, we can tell if a smile looks good or not. Okay, but at least you know, and I'm not saying that this is the done deal, but you're going on the right track if you start this way. Okay, now this patient was also over close. She had lots of wear. So this is not about occlusion today, but what we did for her was we made her a coist deprogrammer. So this is the coist deprogrammer here. You can see basically it's like a Lucia jig at the front there, but it's clipped into the patient's mouth. So it just allows you, allows the patient to wear this for longer, which is a really nice thing, because what I did for her was I gave it to her and I said, can you wear this a bit every day? And it starts this process of deprogramming. And I said, will you put it in first thing in the morning and then come and see me on that day? And then it's given her ages and ages to allow her to deprogram. And then what I did was basically I had a look, and here you can see what that ramp looks like from a more occlusal position there. And then you allow the patient to slide forwards and back, and I never push. Yeah, they used to talk about retruded position, but you can really, if you manipulate patients and you get it wrong, you can over retrude patients quite easily. So what I do is I try and let the patient lead. So I will get them to slide forwards and backwards, forwards and backwards, forwards and backwards. And then when they seem to be going to the same place backwards each time, I'll ask them if it's comfortable as well, because I don't want them to overkill it and have discomfort in either the joints or in the muscles. Because like I say, we don't want to lock them into a position that becomes very difficult for them to tolerate later. So we want to put them in a nice place that they seem to be going back to an awful lot. And then all I do at this stage is I scan the patient at the height that I feel looks right. Okay, how do I do that? So I'm going to allude to the visual things that I'll do, because I've got some photos later. But once I'm happy that it's right, then I can scan the upper and the lower jaw, or in fact, mostly I delegate that to my therapist. And then all I'll do is I'll come in and I'll do the buccal scan. Okay, so instead of having to use Blue Moose or whatever to register that by, I just do it with the scanner. Okay, and then what we're able to do then is to fabricate models. So these are obviously the printed models of the upper and the lower jaw. And then the height, the space between those models, you can see has been fixed by those little pins that are coming out. So they lock in, but the teeth won't meet, yeah, at that particular height. And then what my technician, Lino, does is he prints the models, but he also does a design and then prints a skin, okay? And this skin clips onto all of the teeth. And you can see how it just sort of fits in, clips on. Okay, and that's how it looks without the model there. You can see it from the top with all the fit surfaces there. And we try that into the patient's mouth. And she says, yes, I love that color, let's do it. No. Unfortunately, we haven't got to the point where we're putting character into that one. So it's just white. But what it does is it gives us an idea about proportions, lengths. And the thing I love about this is that although I know it's nice to have a wax up on a model, okay, and show that to a patient, the truth is, it's difficult actually. I find it difficult to understand exactly what that smile is going to look like when it's in the patient's mouth. So I don't feel like patients with the lips round and all the rest and the mouth framing the smile, I don't really honestly believe that they're able to discern what that smile is going to look like. So they could in really good faith say, I love it, I think that looks beautiful. But then when it goes into their mouth, it's not what they were expecting. So to be on their side, an advocate for them as well, we need to try to give them the best possible chance to say no beforehand, because that to me is not bad, but we can probably see is not exactly right as well. Okay, so you can see that upper left one, that distal edge, not right. Okay, so she picked up on that. Of course, I picked up on it as well. And so what we did, thankfully, she was happy with everything else, as was I. And again, this is just an idea of how it looks in the mouth. And so you'll see now, that's how the smile looked before. And all I've done is I've disked that distal edge. See? Just that distal edge there on the upper left one. And then because it was such a small thing to change, all I've done is I've told the technician, this is great, go for it. I'm happy. And can you just manage that distal edge off that upper left one? If it was a more fundamental issue, there were problems, then I can still bond composite on this, change line angles, do a lot of adjustment actually. And then I could scan this again, okay, rescan it, and then send that back to the technician and say, this is what I want the prototypes to look like, or this is what I want the final job to look like. It just depends on what kind of a case we're doing. Okay, so you can see here, this is our patient on the left without the skin. So remember, this particular skin has been driven by the opening that we decided to do based upon the COISTI program, okay? So for her, that's a full mouth, and it's gonna have height, yeah? Obviously, it's gonna have a bulk on the occlusal surfaces. I'm gonna put her in a different position. So you can see what we've done here is, if you look at the face height thirds, we've improved the lower face height. Okay, she's got those marionette lines and all the rest. And so we've improved the lower face height so they're more even now. So this is her on the right with the new OBD. Okay, and you can get an idea of what her new smile looks like as well. And she's happy. She's happy with that. Okay, once again, you get to see those face height thirds better. Get an idea of what the smile looks like. And then this is her in the final job. So moving that to as a blueprint, if you like, to drive the restorations in a digital way is dead easy. Okay, because my frustration was always with analog that you could really do a nice prototype situation for your patient. You take a lovely impression of that, but there is still then some guesswork getting that to be copied beautifully. Whereas this is easy. This is just the same program that drove the shapes of all the restorations in wax or in resin or whatever it was, will now be the same program, and you just change the material. You change it to whatever you want to. This happened to be zirconia. She had bridges actually. There is a story with this case. I tried to do the anterior units in a porcelain. I think it was feldspathic porcelain, lucite reinforced. And then the posterior units we did in zirconia because there were bridges. And although the shades were correct, it didn't look right. It didn't look right at all. You could tell that there was a difference. And so I ended up having to remove all of those bonded restorations, which was, as you can imagine, not exactly fun. And then I got the new restorations made in zirconia. So the whole smile looked better. We still cock it up. I mean, I just find more and more elaborate ways to do it, to be honest. When you get the other bits right, I find a more funky way to mess up the case. But no, I've learned now, just stick to the whole case being one material, and you're laughing. And that's Ingrid now. That's the trial smile, and you can see she's happier, smiling in a way that you wouldn't have thought she would want to. And now that she's got her new smile, and there you go. Right, so that's, hello.
Just got a quick question here from someone. Do you always use provisionals and mock-ups as these acrylic shells?
That's a great question, actually. No, I don't. I use provisionals when I'm opening the OVD beyond the point. Okay, for two reasons. Okay, so one is functional. So if I'm opening the OVD beyond the point of the first point of contact, opening it more, then I want to use provisionals to test drive the new occlusion. Okay, so that's one way. However, if all I'm doing, if I'm able to gain enough space, let's say, for example, it's an anterior wear case. If we're able to deprogram them and just have the first point of contact posteriorly, and the jaw shifts a little bit, and that shift opens the anterior teeth up enough for me to make reasonably looking restorations, then I don't provisionalize that. I'm happy to go to final. So that's the really good caveat, because what you're doing there, you're not opening their muscles up anymore. You're actually putting them into a better position, so you know that they'll tolerate it. So from a functional point of view, it's only if I'm opening beyond that point. The other one is if I'm still unsure about the aesthetics. Yeah, so for example, if there is a big, let's say there's a big change, and I really want to make sure that the patient's going to accept this, then I'll do it in a provisional. Because I think I've done it, I've gone to finish before, and then they've still just been unhappy. And it was my fault. It's because my communication of the case beforehand really wasn't as eloquent as I thought it was in terms of what I showed them and what they saw. Okay, so because there was a bit of a change, then they were unhappy. So I'd rather slow things down, and let's not make any bones about it. I'm billing them for this, by the way. Okay, I'm billing them for that predictability. But it means that they are happy at the end, because everything I've said to them, I'm going to do virtually is done. And I mean, in terms of communication, actually, we'll come on to this in a bit now, because actually we'll come on to it with this topic. Because the next topic now, so that was communicating with a patient, okay, visually, feel and all the rest of it. And now I'm going to talk to you a little bit. Sorry.
Another question. How long does it take to open the bite using a bite raising appliance?
To be honest, it doesn't take long. It doesn't take long. I will probably let them go for about a week. And that's just me being a little bit, because you can open them up in an appointment. Yeah, you could use a leaf gauge and just get them to a point where you can see that they're reproducing that movement all the time. And then you're probably happy to scan at that point. The distinction is whether they've got any joint pathology or muscular issues going on. Because what can happen is that you can get them into a position that you think is reproducible, but if there's any kind of joint pathology, then now that they're in a happier place, if there's any inflammation, either extracapsular or intracapsular, then that will reduce and it will modify slightly their position. So if you allow them this business of deprogramming over about a week, sometimes that helps. It just helps them. But no, I've got patients that, let's say, for example, if it's that first one where we've just got moving them to the first point of contact, then I'm happy not to even send them away with a deprogrammer. I'll just do that in a single appointment, and I'll use a leaf gauge to do that. A leaf gauge, for those who maybe have not seen one, it's about 1 centimeter thick, okay? And it's just made up of acetate leaves that fold out. One at a time, one at a time, one at a time. So you can open and close that diameter by taking leaves in and out. So let's say you stick them all in and you get them to slide back and forth, back and forth, back and forth, back and forth. And you can see that it's starting to relax. You can take some of the leaves out, and at the point at which they are touching, they'll be able to discern it on one side or another. And you can just stick some articulating paper in, get them to close and pull it out. And if it pulls out freely, there's no contact. If it doesn't, if it tugs, then you can verify that they've got contact there. And that's a really nice way of finding that first point of contact. Okay. And if you overdo it, let's say they're touching on both sides, just put a few more leaves back in. But you'll notice that sometimes in the process of deprogramming someone, they will contact somewhere. Okay. And then you keep it in. Okay, and you keep getting them to slide back and forth, back and forth, back, and then they might start contacting somewhere else. And this is that process of deprogramming that's happening. So the mandible is shifting. Yeah, its relationship with the maxilla is changing a little bit because you're removing the influence of the teeth on the bite, and what you're now leaving is the influence of the jaw joint and the musculature. Okay, and that's getting you into that retruded arc of closure, if you like. So I find that's a nice, easy technique for someone cack-handed like myself. I don't want to be ramming people back and getting them into the wrong place. Right. Rob, any other questions? Because those were great questions, both of them.
No, that's all good for now, Nat. Alif, that's really cool. No more questions at the moment, so carry on going, mate. It's all good.
Lovely. Thanks, buddy. Thank you. And thanks everyone for your questions as well. Okay, so the next thing we're going to talk about is something called ELAB, which I came across a couple of years ago or so. And this has really helped, okay? Because I find that shade is a difficult thing. Okay, let me talk to you about my understanding of shade as well. I think we do get too hung up on shade, okay, sometimes. And actually, the thing that we should focus most on is luster. Now, the reason I make that comment is because if you think about a smile, natural teeth, there will be teeth with different colors in there. So a slight change in color can be absorbed within a smile design, if you like, or if it's a single unit going in. But if the luster is wrong, because in a natural smile, teeth are brushed at the same time, they eat the same food, so they will wear at the same rate. So if you've got teeth that are highly, highly polished, and then you try and fit a matte restoration in it, it won't be tolerated, okay? It'll stick out like a sore thumb. So that's just a contextualized shade. However, if you do get the shade wrong, and I think it's the value, actually, so the brightness of a restoration, if you get that wrong, that really is a giveaway that you've got a restoration you've got a restoration rather than a smile. And actually, I don't know if Bob has joined us this morning, but a really, really good guy, Bob McClelland, it's he that taught me this, that a really good day at the office is one where you fit a restoration and it just disappears into the smile. And when we can do that, I really feel quite happy, quite proud, because it's not always easy. But this has helped. Okay, so what is ELAB all about? It's a way of communicating color to the lab. Okay, the problem with shade tabs is that they're not standardized. There's actually differences between like one shade tab and another. Okay, so that's never a good start, is it? They're not necessarily all calibrated for all porcelain powders. So the point there is that if you're telling your technician A3, the powders he picks up, which tell him that it's A3, might be different to a different color to what you're expecting. So there you've set yourself up for failure again. Okay, and often they are fine. So you remember about color, so it's made up of three things. So chromaticity, which is two, that's hue and chroma. Hue is the prevailing color. The chroma is the intensity of that color. So if you, the analogy I always use is Ribena. So Ribena, one drop all water will have a very low chroma, okay, small amount of color. And as you pour more and more and more Ribena in, it becomes more and more chromatic. So actually they are...
Alex, one more question here from Victor. How do you grade luster?
Grade luster? Oh, yeah, wow, it's a good question. Okay, for me, it's not as difficult because I'm generally getting a very matte restoration out of a milling unit, and then I will polish it. Okay, so I'm going to polish it and then I'll hold it up against the dentition, and I've got a protocol for polishing, various steps, and I will just take that protocol onwards and onwards until I'm happy that the luster I have is matching what's in the mouth. But yes, communicating that to the lab, I think this will be helpful. Photographs, I think, are probably the best thing, to be honest, because there isn't a grade. You're right, there isn't an A for luster at all, really. So yes, that's a good question. It's a good question. But yes, so the shade tab's good for chromaticity, but actually not very good for value. And unfortunately, that can be the giveaway. So in order to do ELAB, what do we need? We need a camera, obviously, but you need to have a polarizing filter on the camera. Now, what a polarizing filter does, so if you imagine your flash, ring flash or twin flash, will have light that will be emitted from those flash, and then it will find its way onto the tooth and then bounce back. Okay, so often when you're taking photos, you might see little white spots on your teeth, and that's obviously the incident flash that you can see. But the light that comes that way will then mask, the brightness will mask the internal characterizations of the tooth. Okay, so if you can remove that flash, then you can see through the tooth, you can see more of it. So you get more beautiful restorations that way. The way it works is by having like polarized light. So a polarizing filter will be placed on where the flash is in one orientation. And so that will take light of one wavelength out as it's going towards the tooth. Okay. And then when it bounces back, the filter paper, the polarizing paper, is orientated the other way. So as it then comes into the viewfinder, the light is removed from the other wavelength, if you like. So now you've taken basically all the incident light out. And I'll show you some photos in a second so that you can see how much more detail you can see when the light is polarized. The other thing you need, so basically the polarizing gives the technician a chance now to really see the internal characterization and give you more beautiful restorations. Okay, so the other thing you need to do is to have a way of calibrating what he is seeing on his screen so that you know it's exactly the same as what you see in the mouth. Okay, and the way you do that is with a white balance gray reference card. Okay, so this is the polarizing filter. So you can see it's got filter on the side bits there, which is where the light source is, and then obviously you've got the other filter just in the middle there on the viewfinder. Okay, and then this is the white balance gray reference card. So basically it's a gray, okay, but it's a known gray, okay? So the exact color temperature of that gray is absolutely set in stone, if you like. And so when you have that in your photograph, the technician can put that into a piece of software called Adobe Light Studio and calibrate the color of this gray so that then he knows that what he's seeing on the teeth, what's on the rest of the photo, is exactly what we see in the mouth. Okay, so this is what the photo would look like. And that is the polarized photo. So you can see, can you see, if I go back there, you can see those white spots, the glare around the tooth, and that's all been removed there. Okay, and then this is the software, this Adobe Light Studio, and then you can play around with that and tinker around with that histogram on the right. And that allows you to change the color temperature of the gray card so that the rest of the photo ends up being the right color. And you can see here on the left and the right, that's the non-polarized photos, both of them, but that's what the technician will have received on the left-hand side. And this is after he's changed the reference. So you can see how much it's dropped. So if you can imagine, if you had your crown made thinking that the left-hand side was the right color, you can see how the value would not be right. And once again, you can see the same things done with the polarized photo. Polarized without color correction on the left and with color correction on the right. Okay, so this is how we can use it. So this is a patient who came to see me, obviously unhappy with his aesthetics. So we had a chat with him about what we could do. And that's how the upper left one looked. So what we can see there is after we've done the crown, we've been able to put a bit of characteristics into it just to get it looking a little bit nicer.
Hey, we've got a couple of questions here. Sorry. Do you take shade pictures before starting any prep, any tooth prep?
Yes. Sometimes. I try and get photos taken at different stages. So for example, if they're having whitening, then I'll get pre and post whitening ones. But let's say it's a non-whitening case, then I would generally get the ELAB photos taken before prep, yes. I think that's better. And I would generally take a shade photo as well. And I'll take a shade, and definitely taking a shade is done better before you prep, because our eyes also can become saturated with the color of the tooth, and that changes our perception of what we think the shade is. So okay. Definitely beforehand is a good time to do it.
Fantastic. One more question as well from Fergus here. Is the grey card useful even if you don't have a polarizing filter, or do they work together?
Yes. Yeah, actually, you're right. You can use it without. You can use it without. What you'll miss is the ability to do the internal characterization, but yes, it will definitely help your technician. Like for example, if you can send them shade tabs as well as the gray reference card photo, then yes, you will help them to calibrate it. But just make sure they're ready for the setup and they know how to use Light Studio and all the rest of it, because without that, they need that to be able to manipulate the photo, to change the color temperature of that photo. Otherwise, it's meaningless then.
Okay. Just one more question. Sorry. What's the simplest bite raising appliance you used?
Leaf gauge. Yeah, leaf gauge every time. I think that's my go-to. That's my go-to. The Coist deprogrammer is my showboating one when I know I'm presenting a case. No, I'm joking. I use the Coist deprogrammer sometimes if it's a big opening that I need to do and I'm worried that there's joint pathology. But honestly, I think leaf gauge is my go-to one. I just like the control of being able to take the leaves out and just control the width of it. That's the nicest thing about that. So that gets used the most in practice.
Okay, one more question. Should the shade tabs be used at the same time as the grey card?
Yes. Yes. Yeah. To be honest, remember, I think that what we might be getting at here perhaps is dehydration of the tooth. Correct me if I'm wrong. I'm sorry if I'm wrong. But yes, I think try and get your photos and the like all done at one point, because yes, that is one thing. When you've been working on teeth for a while, then they can become dehydrated, and that will also affect your perception of shade as well. Lovely, lovely. If there's any more, keep them coming. I like this. It's good fun. Right, so just another case, obviously we can use that for implant treatment as well. When it comes to upper centrals, we know it's a difficult case. I was going to talk to you about something I normally say to patients as well, when I consent them for single centrals, whether it's crowns or implants. If you frame we really want that tooth to look like a tooth. Yeah, we don't want it to stick out like a restoration might. And so what we might have to do is 2, maybe 3 attempts to get it right, because we know the fit will be reasonable. We know that the bite will be fine, but the color can be really difficult to replicate. So I'm going to take as many attempts as it takes, if that's okay. And if you say you're happy and I'm not, then we might have to do it again. If I say I'm happy and you're not, we might have to do it again. And at the point where we're both happy, then we will say that's it. And we won't charge you anymore. Well, that depends. You add or subtract that bit depending on your pricing strategy. But I say to them, we won't charge you anymore, but I just want you to have the tooth that you deserve. And when you tell them that at the very, very start, then if you have got a remake, you've taken all that pressure away from yourself, because you're explaining, communicating to them at that stage that you're in it for the right reasons, I feel anyway. You're not like excusing yourself afterwards. So implant there, we take the photos and you can see that one's been color corrected. That's the polarizing filter photo, and then that's the one with the grey reference card in. And essentially all that's doing really is it's helping to communicate the characteristics of the upper left, well, not even just the upper left central, but some of the other teeth, so that the technician can see those cracks better. It can see the mamelons and the blue and all of those things that really give the tooth its beauty. And so then he can make us an abutment, and then we can whack a crown on there, which is a reasonable crown. And I know it looks a bit funny. It doesn't look like a tooth because there's still a bit of soft tissue, like healing to do there, but it's not a bad job. Okay, so that's communication with the lab. The other thing, of course, is I like to communicate with the lab by using scanner. So I will scan everything. I just think it's more accurate. The other thing I like about scanner is that I can marginate the prep. So then there's no, is it here, is it there, all the rest of it. So I find that works really well. And so then the fit is sort of taken care of. We know that side of things is great. We can just concentrate now on these small details to get that restoration as nice as possible. Okay, so the last topic I'm going to come on to then is communication of a plan into the mouth. Okay, so this is the workflow I use, and we're really going to focus on the first half of it. But when I see patients for implants, then I need to get a scan of their mouth. So I generally get my therapist, Neil, to do that. And that's in lieu of an impression. And then once I have that scan, I'm able to do a digital wax up. So I can now, I can guide this treatment from a prosthetically driven position, okay? Which is what I think we should all be doing. Long gone, thank God, are the days where we just cut a flap open. Ooh, there's a nice bit of bone there, let's whack an implant in. We now want to know exactly where the tooth needs to be so that we can backwards plan where our implant needs to be, and graft and all the rest of it, so that that implant is now going to support that tooth and hopefully give us maybe screw retention as well, because I think screw retention is a nice, easier thing for the long term. And I think it's a helpful way to backwards engineer, but then take our treatment forwards. Okay, so we're going to scan the patient, and then I need a CT as well. So we've got the Sirona CT. I know I'm not sponsored by Sirona at all, not for this presentation, but I'm just going to talk to you about what I use. Okay, and it just happens to be that that's the kit I've got. Okay, and then what we need to do is merge that data. So essentially, we've got now a scan which is showing me teeth and gum, and then we've got another scan which is showing me teeth and bone. And the teeth on one and the teeth on the other will merge, and then that's now gives me something which has got teeth, bone, and gum, which is nice. It's helpful, okay, because I can then also superimpose the tooth onto that X-ray scan, the one I'm planning, and then I can put the implant in exactly the right place. Okay, and then when we have that, we're able to make a guide which makes me put that implant in the right place. Okay, let me show you a case, and then all will become clear, I hope. There's a lovely gentleman who presented with an anterior space 5-unit one. You can see he's got canine on one side, doesn't have one on the other. Okay, so we decided we would make for him a 5-unit bridge. So the first step, as I mentioned, let's take a scan of his upper jaw. We need one of the lower as well, because we're planning the case. Okay, and then what we do is a digital wax up of what we want those teeth to look like. And sometimes I get my technician to help me with this. I'll send it to a technician. I work with a chap called Lino Adolf, he's a brilliant guy. And I'll sometimes get him to do all the shapes and the sizes and the occlusal plane and everything. So it's all dealt with. It's a nicer workflow then. Okay, and this is what essentially what we want the restoration to look like at the end. And then what we've done here is we've merged the CT with that CEREC scan. So you can see on the top two, especially that one on the top right, where we've got that stone colored bit. So that's the STL of the model. The blue there is the wax up of the teeth. And what I've done upon that, so what I've done actually is obviously I've put implants onto that plan, but if you can look at the lower middle one, you see how I've positioned the implant so I get screw retention in that particular restoration, and I've done the rest in all of them. So now I have
just one question: are they milled in house? Do you mill in house?
You can. I've stopped now. Okay. The reason is a block for milling in house is about 35-40 quid. And it's a messy, long process. It takes about 40-45 minutes. Noisy as well, actually. It doesn't sound the same as a normal restoration being milled. And I found a lab that do them for 65. So I just feel like I'd rather send it off, and then they'll either mill or print the guide, but it fits. Yeah, it fits. I don't have any fit issues. I never did on the CEREC. When I milled them in-house, I'd never have fit issues on the ones I get sent from the lab. So I'm happy either way, but I just feel like it's worth spending the extra 20 quid and having it done somewhere else. And that's a really good question, actually, because, you know, when I first started out with CEREC, I know it's expensive, right? It's a big investment, and we worked it out to be about, I don't know, almost £2,000 a month. I thought, great. So I know what I need to do is reduce my lab bill, so cut the lab out of everything. And if I reduce my lab bill by that much, then this was a good investment. And it was a really silly and short-sighted way of thinking, okay? I've realized, thankfully, since, that if I bring the lab back in, I want them to do as much as they can anything they can do that I can't, no, that I am allowed to delegate, put it that way, I'm going to delegate it away. I want to only do the stuff that I have to do. And what I've found is because CEREC just allows me this freedom to plan better, to communicate better, it's just grown my practice. So now more patients say yes, like in a simple way. For example, oh, I don't like impressions. It doesn't matter. We can scan the teeth. You can have a crown. Great, lovely. That's a case I can do that I wouldn't otherwise be able to. I have patients like this that I say, well, look, if you're unhappy with your smile, would you like us to show you what your smile would look like before you even have to part with a penny? And sometimes I get hit. Yeah, I get stung and I incur costs, but it's not. But I'm magnanimous enough about that because the number of people that go ahead with cases is way more than I would have ever had before if I was not able to communicate the smile to them in such an eloquent way. So there's been massive improvements in my practice as a result of it. And I think this business of thinking big and delegating to the rest of the team. So like you overheard that scanning is done by my therapist. We're now going to have a program for nurses to start doing scans as well. And essentially, I'm doing digital dentistry, I'm doing implants. And everything else, endo, dentures, fillings, I delegate away in the practice because I just want to focus and do the stuff I love. Because I know my patients get the best out of me when I'm doing the stuff that I love. So that's my rant.
Yeah, it's not a rant. That's good. A question here from Hamza. Which lab do you use again?
Okay, so I use Majestic Smiles. That's a chap called Lino Adolf. Really good guy. So Lino and I, we teach together. We do the CEREC training in the UK, the both of us. And he does obviously the technical aspects and I do the clinical aspect. He's a top guy. So anyone who's looking to push their digital to another level, you leverage it more, great to work with him because he pushes me. Yeah, it's been one of the finds. And then I also use another lab local to me in Leicester. They're the ones that just print the guides for me. And that's JVara, and they're a Leicester-based lab. And again, they've got in-lab, which is the CEREC software. So any CEREC dentists want to do planning and stuff with them, they're excellent, really, really good. Lovely. So what we can see here, we've got the plan now. So we've just to recap, backwards planned. Okay, we've decided this is what my smile wants to look like. So what my teeth want to look like. It doesn't have to be smiling. Posterior is the same thing, yeah. But this is where the position of that tooth needs to be. And because the position of the tooth is locked in, I am now going to put my implant into the correct place to best support that restoration. Okay, so that's the plan. And from that plan, this is not difficult to do, a couple of clicks, and you can send this to your lab, or you can send it to SciCat, who are a sister company of Sirona, and this happens to be a SciCat guide. And it's with SciCat, it's about maybe 300 quid, okay? But my rationale was in-house, so it's changed now since I've been using Vara, because they can do multiple implant guides. But at this time, when I was milling, you can do a guide for a single unit. Just a single implant. So for this case, I would have had to have milled 3 separate guides, which is just a faff I can do without. I was happy to pay extra, just have one guide made, and then that's got all 3. And you can see they are pilot guides. So pilot is a lovely way to start doing guided implants. One thing, you don't need to invest in a fully guided kit, but I really feel that the most benefit is being given by doing the pilot. It gives you the positioning for where that osteotomy needs to be. It gives you the angulation 3-dimensionally. Okay, so that's height, buccolingual and mesiodistal. And it also gives you the depth as well. Now, if you've got that locked in now with your primary osteotomy, then all you're having to do is make that hole bigger. Yeah, most of us should be able to manage that. So that's pilot guided. The other thing as well that I find is that if you have any concerns about bone burn, it's a legitimate concern, because if you've got a guide in the way and it's not allowing coolant in, then fine. Do the first one, okay? And then your subsequent enlarging of the osteotomy will be done in a conventional way. You'll have sufficient irrigant there. So if you have heated that bone that's immediately around the osteotomy, around that thin osteotomy, you'll cut that out with the next drill anyway. So it's a nice, I find it sits with me as a sensible way of doing guided surgery. And I have dabbled with fully guided as well. In fact, there are some cases I still do fully guided, especially my full arch ones. I tend to gravitate to full guided there. But I like pilot. Pilot's nice. Okay, so what I've done in this case, I've fitted the guide in, I've tried it in, and then I've pushed something sharp through. I think that's just a fissure burr, surgical fissure burr. And what that does is it allows me to put a little puncture mark on the mucosa there, but I'm going to raise a flap. Okay, so what that's done is it's going to allow me to basically join the dots. Okay, so it allows the flap to be raised in a nice, predictable, easy way. Okay, we'll get that up. So I'm just going to do 2 small flaps there. I'm not going to raise the whole thing. Slightly keyhole approach. So you can see the bone there. Let's stick the guide back in, check everything's all right. And then we start doing that primary osteotomy, obviously guided. And there we go, happy. Yeah, so that's the primary osteotomy is done, both of them on the right-hand side, and there'll be one on the left. We check, verify, spacing looks good, angulation looks good, happy days. And then essentially we make those bigger, can stick some implants in they are, healing caps, same on the other side, implant in, and there we are. And then we just sew it up, and that's good. It's good. I was happy with that. It went well, and then that's how it looked after a couple of weeks. Took the sutures out, and this is the OPG I took on the day of fit, on placement rather. And what I thought would be interesting to do is to overlay the plan. And you can see it's not bad. It's not bad. So I was quite happy with that, as you can see. So no, that was a good day at the office. And I can take you through another case, just because it illustrates a different point then. So I mentioned with guided, the thing that I like is that you can get the position of where you want your osteotomy to be right, which obviously is not that difficult if it's a single tooth. Generally, midway between the 2 teeth will do okay. But I hated this case, absolutely hated this case, where you've got a 6 and a 5, yeah? Because what you can see is a space, isn't it, between the mesial of the 7 and the distal of the 4. And then you've got to do all this advanced mathematics in your head to work out where the 6 needs to be, because it's not 2/3 of the way along, is it? And the 5 needs to be here, but it has to be biased a little bit closer to the 4 because it's a smaller tooth. I hated it. So at least when we can do that same case, you can see the teeth have been planned, the implants have been put in, planned for screw retention. I'll come back to that point in just a second, but let me just mention something else before I forget. So this is about when do we do guided, when do we do flapless, and all the rest of it. So a lot of people think that if you've made a guide, it has to be flapless, but I want you to think that couldn't be further from the truth. Most of my surgery, I raise a flap for, okay? This is a few cases that I'm able to do flapless. So what's the first constraint is how much keratinized gingiva you've got. Okay, so if you've got bags and bags of keratinized gingiva, you're happy, but you need keratinized gingiva all the way around the implant, I think, for long-term success. If it's in non-keratinized mucosa, it's going to be sore for the patient to clean and brush. It's movable. It's less robust. So I think the soft tissue will be a problem later. So if you've got inadequate keratinized gingiva, the last thing you want to be doing is taking a punch to it and throwing it in the bin. The thing you want to be doing is either grafting beforehand, or at the very least making a nice incision between and then repositioning that around your implant so that you've got keratinized mucosa on both sides. Yeah, it's precious. The next thing, you need to be doing guided surgery. Okay, so let's get this right. If you're doing flapless, it needs to be guided. Okay, if you're doing guided, it doesn't necessarily need to be flapless. Okay. You need to have an adequate safety margin, because as much as I purport how accurate and all the rest of it, it's not. Okay, there are issues, and one of the things can be sleeve tolerances and the like. So that means that if you put your drill through the sleeve, sometimes it will wiggle and waggle a little bit, and that small change around about where the guide is can make a big change at the very top near the apex, and it can be significant. So if you are relying on your guide to give you like 0.5 millimeter away from a vital structure, then I would still say you're better off raising a flap so that you're able to look at where the guide is putting you, but then also to verify it visually and how you would if it were a conventional surgical approach. Then the last thing as well, of course, is you need to have adequate bone. Because if you've got a nice amount of chunky bone, you don't need to graft or augment, great. But if you've got to graft, then you're going to have to raise a flap anyway. And that's stuff that's courtesy of a chap called Herman Gallucci. So he's from Harvard. Okay, so in this case, this is the one that we planned. You can see I've started the process and I've cut my first osteotomy. And this is the crux. This is the photo I wanted to show you. Because what you can see here is actually osteotomies that are in good positions. They are in good positions, I assure you. But because of the angle at which I've taken that photograph, or my assistant took the photo, which also happens to be the angle that I am looking at that situation from as the operator, it looks hopeless. Yeah, it looks like that mesial osteotomy is way too close to the fore, way too close. Why? So this is the issue with placing adjacent implants. So I'm sorry I haven't got a cursor, but let me just walk you through it. So you can see where the angle that we are looking at from. So you can see where the eye is, and you can see that I've got the 4 on the left and I've got the 7 on the right. The red line is the actual width of that edentulous ridge. That's the actual width that I can work on. And the white line is the perceived width of that ridge. Well, not width, but you can imagine, yeah, the length of that edentulous space. And the reason is because from that angle, you can see the 4 casts a shadow. Yeah, it casts a shadow of an area where you can't see that bone. So you don't necessarily factor that bit in to your apportionment of the space that you've got. Okay, so if that happens, although you would want your implants to go there, you can end up transporting everything distally. Okay, and then that's a problem. So what you really want to be aiming for is a case where you're getting there or thereabouts screw retention. And so that's what I'm aiming for. And when I do guided surgery, it takes all the headache out of it. And when I started doing all that merging and scanning and blah, and blah, and blah, of course, that used to add on time. Okay, but I found very quickly that it made my surgical procedure far quicker. Okay, so I got a lot of that time back. And also, this is time where I'm clicking, yeah, coffee, click on the thing and play a computer game and put the implants in. So it's relaxed time, it's chilling time. Whereas when you're gowned up and hot and like stressing about where it needs to go, that's where I want to have as much help as possible, because that's the difficult time. It's the butt clenching time, isn't it? So the guide helps to speed things up, but then it also makes it far less stressful as well. So you can see screw retention there. Another case. So just show you that we like to have things as well as we can screw retain. But I tell you, I'm not skillful enough to do that freehand. So that's why when I guide things, I really feel confident that it's going to be a good case from start to finish. Yeah, happy again. Okay, so the last topic I'm going to just touch on, because it's very similar to what we have spoken about already. It's just building on it a little bit. But this is when I'm doing full arch stuff. And really, the important thing I want to talk about is the accuracy of different types of guides. Okay, because there are tooth-borne guides, which are regarded, and we know now, are the most accurate. You have bone-supported guides, and you also have soft tissue supported guides as well. And sometimes you have to use those. If you have no teeth, that's what you have to do. But if you're treating a failed dentition, okay, so the patient presents to you and they have not been to the dentist, for example, all their life, and they say, I hate my teeth, they're rubbish, and I really want to have a nice smile. And you do a risk assessment and you say, look, I think the best thing for you actually is probably to remove them all and let's do something implant supported. Then this workflow, I find, makes things a lot easier. So what I tend to is on